Gerontological Society of America with support from Pfizer. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. We'll also have a question and answer session immediately following the live, and we'll be accepting questions through the questions feature accessible on the right-hand side of your screen. I'm Steve Albert, one of the speakers for today's program. I'm joined by Dr. Michael Vitiello and Dr. Thomas Roth. I'm professor and chair of the Department of Behavioral and Community Health Sciences at the Graduate School of Public Health at the University of Pittsburgh. Dr. Vitiello is professor at the Center for Research on Management of Sleep Disorders and the Northwest Geriatric Education Center at the University of Washington. Dr. Thomas Roth is director of research and division head of the Ford Health System. We're very pleased to be part of this important program, and we think you're in for an exciting hour. So we can all know just a little bit more about who's in the audience this afternoon. You'll see a poll displayed on your screen. You can click your response and then click the submit button to lock it in. We'll be quiet for a moment while you read through the choices and make your decision. For the poll, please tell us who you are: academic, industry, government, medical practice, or other. Oh, I think you can get a look at yourselves. We have about 2/3 from academia, 11% from industry, nearly a quarter from medical practices, and a smattering from some other areas. And we welcome you all to today's webinar. Let me move on because our time is short. Let's begin then with the first of our presentations. I'll be speaking. And let me begin with a caveat. We're going to cover today aging and sleep disturbance, the current state of OTC therapeutics for sleep disturbance, and a little bit about what we know and gaps in therapies and clinical practice with respect to OTC sleep aids. We're not going to talk in detail about supplements or behavioral therapies, and we'll only partially talk about prescription medications. These are all big topics that require separate discussion. Our focus today is OTC. So, our objectives are to increase the understanding of sleep health and OTC sleep aid use in older adults, and we're particularly interested in identifying opportunities for promoting safe and effective use of OTC sleep aids in the older population. This webinar today represents the culmination of a long effort with many colleagues. As you can see from the slide here, we held a summit in June of 2014 on OTC sleep aids and sleep health with a focus on research, education, and advocacy. We then took that a step further and presented results at the Gerontological Society meeting in Washington in November, along with a Congressional Hill briefing. We've prepared some white papers and other materials which will be available on the GSA website, and we'll come back to these a little later in today's webinar. And today we'd like to bring some of this together and update you on the results from our summit and GSA symposium. So a little bit of background. We have information from the CDC Behavioral Risk Factor Surveillance System, for the first time a sleep module, and state-level national estimates of sleep disturbance. That's the graph on the left. And tiredness during the day, that's the graph on the right. You can see some age trends and gender differences. And you'll note as well that sleep disturbance reaches its maximum in the 50s, not in very old age. And tiredness actually goes down for some point in the 60s as people transfer out of work potentially, but then increases again in older ages. This topic has become increasingly of interest for related to poor sleep. The CDC Behavioral Risk Factor Surveillance Survey I just showed you a minute ago found a very disturbing report that something like 3 to 4% of Americans report falling asleep at the wheel. And of course, our American Automobile Association is very interested in information of this sort, and I refer you to this report on their website, which came out in April of 2014. We also are very interested in what people think works when it comes to supporting sleep. This is shown in a report published in the Journal of the American Geriatric Society on a scale of 0 to 4, where one of these techniques at best would earn a 4. No sleep therapy reported by this sample of older adults had a score greater than 2.5, and prescription sleep medicines are at the top. But you can see that people choose a wide variety of techniques to support their sleep. Some of them are obviously not very good for you, like alcohol or cigarette smoking, but this is what we see in these sorts of surveys. And finally, we have some information from national polls, this one conducted by the National Sleep Foundation. There are cultural components to sleep. For some reason, Americans seem to sleep a half hour less each night on average than Canadians and Mexicans. And so sleep, we have to remember, fits into a larger picture of expectations about daily performance, role demands, environments that support or interfere with sleep, and many other factors. So, many things to learn about sleep, which is clearly one of those fundamental components of well-being. Today we're going to look a little more carefully at the prevalence of sleep disturbance and some of its correlates. We'll also look at how older adults actually use OTC products to treat sleep disturbance. We'll hear a little bit about the efficacy of OTC therapies, and we'll come back to how people actually take the medicines and what we could do to support them. So at this point, let me turn it over to Dr. Vitiello. He will talk more generally about aging and sleep disturbance.
Thank you. What we're going to do in my section is look at sleep in general, try and give you a sense of the relationships between sleep and health, and then turn specifically to sleep-aging interactions. So just to give you a little bit of background in terms of the importance of sleep, although I hope you all recognize that, if you look at some population data that was published by the Institute of Medicine back in 2006, it reported that almost a third of the U.S. population has chronic sleep disorders. This is a variety of disorders, including apnea and insomnia, but it's a significant proportion of the population. There's also the question of insufficient sleep, that is, willful sleep restriction by people behaviorally, which also represents a significant proportion of the population, and may be related to some of the data we see in terms of the impact of sleepiness while driving. Sleep disorders and deprivation are associated with a variety of physical health consequences, and I'll review that a little bit later on. And as you would imagine, the impact of all this is quite severe when you think of it in terms of direct medical costs or indirect costs in terms of accidents, loss of productivity, a variety of other related costs. The impact and relationships between sleep and health is rather complex. This is one heuristic model to give you a sense of that. If you start at the top in terms of people's genetic dispositions, this can impact both the likelihood of them experiencing a sleep disorder, but it also is going to impact their circadian rhythm and how aging is expressed over time, and there are going to be interactions between those two. Both of those can directly impact whether or not a person experiences insufficient or disturbed sleep, both directly and also indirectly. As you see, if you go down the left-hand side, sleep disorders impact a variety of other physiological measures which have an impact on health, both indirectly and also through just deprivation of sleep. On the other side, aging and circadian rhythms and lifestyle choices have a direct impact, and these both may ultimately affect health, but also, as we said, safety and productivity. And this is an interactive relationship, as I think the next slide, or turning our little arrow, would indicate. In terms of how sleep expresses itself as an insomnia-like symptom, there are a variety of ways that we can recognize this. One is that there are alterations in a person's ability to regulate sleep or their underlying circadian rhythms. This is often going to express itself as difficulties in falling asleep or staying asleep and ultimately results in sleep loss. There are also relationships between medical, neurological, psychiatric conditions and indeed sleep disorders that can have direct impact. Chronic pain syndromes, depression, all of these can result in disturbed sleep. And then there are also psychosocial factors or behavioral choices, life stresses, choices of sleep pattern, responses to loss, retirements. You can think of a number that might be age-specific, like the loss of a spouse, where you're much more likely to experience that in older age. Interestingly, if you look at the impact of sleep loss on a variety of physiological functions, and you look at the effect of aging separate from sleep loss on these same physiological functions, things line up with remarkable regularity. There are changes in things like glucose tolerance and insulin sensitivity, or endocrine output, or parasympathetic and sympathetic tone, all of which change with sleep loss in the same way that they change with age. And there's the possibility that these can interact and indeed exacerbate each other as you experience increasing age and sleep loss possibly from other factors. This is some older data that's somewhat at odds with the data that you saw from the CDC earlier in the presentation. But the reason that these numbers are the way they are is that the questions were asked in a much more general sense, where the CDC became much more specific in terms of how they explored the question. Regardless of whether you go with these numbers or the CDC numbers, there's about 20% of the older population that experiences significant sleep disturbance and that we need to concern ourselves with. Poor sleep can impact older adults in a variety of ways, some of which make sense to us, some of which may not. Things like inability, cognitive impairment during waking, where you have difficulty sustaining attention or slowed psychomotor reaction time, difficulties in terms of performing tasks of life, instrumental behaviors, impairments in memory and cognition. There's also, on the physical side, if you will, increased risk of falls, shorter survival, and psychosocially, an inability to enjoy social relationships. There's also, interestingly, and this is relatively new data, an increased incidence of pain, possibly because sleep deprivation literally impacts pain threshold. And when you have sleep disturbance, you're more sensitive to pain. There are also significant consequences in terms of healthcare utilization and consumption, as I've mentioned. And there are also probable relationships with cardiovascular risk and certainly depression risk. The data on those is becoming clearer and clearer, and in fact in depression there are over 11 now prospective epidemiological studies that show that disturbed sleep. What did I do? Cognition. Oh, I did mention cognition. Okay. That was the first thing I mentioned. Sorry. Cardiovascular depression risk in terms of 11 different prospective studies that show that insomnia or disturbed sleep is a risk factor for depression and not the opposite. There's also an emerging literature that shows that insomnia with short sleep duration, that is not just a complaint of disturbed sleep, but an observable shorter sleep duration is related to hypertension, neuropsychological test performance, and potentially mortality. There is, as we mentioned, some interactions between sleep disturbance and health in the general population and certainly in the older population. This data represents 9,000 people 65 plus, and what you see is both insomnia and any chronic sleep complaint interact with health, so that the healthiest individuals show much less proportion in terms of disturbed sleep, whereas older adults who have illnesses are more likely to report disturbed sleep. And that's true of insomnia, that's true of any chronic sleep complaint. Also, there's relatively recent data that shows that there's a risk for cognitive decline in older adults that experience insomnia. This is particularly the case for men, and indeed, if both depression and insomnia are on board, that risk factor goes up to almost double. There's also data, relatively recent data, that supports the relationship between insomnia as a potential risk factor for falls. 30 to 40% increased risk of subsequent falls is associated in women with a total sleep time of less than 7 hours a night, and a sleep efficiency, which is a measure of sleep over time in bed, of less than 65%. So that means a person's time in bed is roughly 35% waking. They're only spending 2/3 of it asleep. Similarly, there's increased mortality risk in older women, with risk factors being total sleep time of less than 5 hours, so this is a more stringent sleep restriction. Again, a sleep efficiency of less than or equal to 65% sleep efficiency, sorry. And also if the person is napping. So if they experience these sleep disturbances, they are much more likely to fall or to have a greater mortality. And then finally, if we're going to look at insomnia on the general global measure of quality of life, you can see that in this group of insomniacs, good sleepers, and severe insomniacs, that gradually with increasing severity of insomnia, there's, if you will, a constriction of the life space on all of these dimensions, so that insomniacs are significantly impaired on all of these dimensions: vitality, social function, emotion, mental health, physical function, and bodily pain. So insomnia clearly impacts cognition, puts you at risk for falls, and also shows significant constriction, if you will, of quality of life for these individuals. Despite this, and despite the prevalence of sleep disturbance in older adults, insomnia is typically underreported and underrecognized in medical practice. Some data back in 1999 from Anticholinergic, Israel, found that 69% of cases where there was disturbed sleep in older adults is never discussed in a medical visit. Further data, more recent data by Reed, if we can see that, demonstrated that in a number of older adults, 1,500 of them, and this was a chart review versus questionnaires, so the subjects were given questionnaires assessing their sleep quality, and then their charts were reviewed to see if there was any mention of it. At least 69% of them endorsed a sleep problem. Fully 40% of them endorsed 2 or more sleep problems. 45% endorsed symptoms of insomnia, yet in the medical charting that resulted from these visits, only 19% of the time was an insomnia or sleep complaint identified. So a lot of older adults are coming into primary care practice with sleep problems, yet they are either not mentioning them nor are they explored. This despite the fact that although sleep patterns change with age, it's a change in the ability of sleep and comorbid medical and psychiatric disorders that result in most sleep complaints in older adults. So these things are potentially treatable. Sleep, similar to nutrition and physical activity, should be an essential part of a healthy lifestyle and needs to be recognized as such by both the individual and by the practitioner. And it's also a potentially modifiable risk factor for age-associated impairments. If you will, it should be a warning sign and possibly a vital sign and should typically be explored. So that, I hope, gives you a little bit of background in terms of aging. I'm going to turn it over now to Dr. Thomas Roth, who's going to tell you a bit more about OTC use in this population.
Thank you, Dr. Video. So I'm going to be talking about what kinds of sleep aids, given this high prevalence of disturbed sleep in the elderly population, what kind of sleep aids do people use? While we are focusing today on over-the-counter sleep medications, which is the last thing on our list, I will briefly just mention it's very important to understand that people use other medications. People use prescription medications. People use herbal supplements, and they sort of think they're very benign because you can buy them in a food store and they're effective. People also use alcohol, and they're very seduced by alcohol because, as I'll show you, they help you fall asleep. And then finally, we're going to talk about OTC sleep drugs, which is actually, you know, the least difficult to understand because we have so little knowledge about that. So moving on, let's start out with prescription drugs. So there really are 3 categories of prescription drugs that are available out there. we have examples. So the first one is called Lunesta or Zapacone, and that's sort of a that's put there for the category of drugs called benzodiazepine receptor agonists. Most of you know other drugs like zolpidem or Ambien, Restoril. There are lots of drugs like in that category. But those are benzodiazepine receptor agonists. The next one on the list is Remeltion, and Remeltion is actually a melatonin agonist. So it works by working on the melatonin system, which is something else. So, again, and Salinor, or low-dose doxepin, this is doxepin at 3 and 6 milligrams, is very much like what we're talking about today. Is primarily an antihistaminic drug. So it works on the histamine system. These drugs have all been double-blind, placebo-controlled trials. They've been approved by the Food and Drug Administration for the treatment of insomnia. And again, remember, we're not talking today about disturbed sleep as much as we're talking about insomnia, which is defined as a disorder which takes at least 3 nights a week for at least 3 months. We're talking about much more today about disturbed sleep and OTCs. And there's no limitation on the treatment with these medications, while there is for OTC medications currently. Next slide, please. And so the next thing is herbal medications, valerian, chamomile, melatonin. And we all have these ideas that they're natural substances, so they can't be very much of a problem. I just wanted to point out to you that strychnine is a natural body substance. I don't highly recommend that for anything known to man. So the fact that it's a natural product does not mean a whole lot. Herbal labels still cannot say anything about treating specific medical conditions. They cannot subject to because they've not been subject to clinical trials for standard prescription and over-the-counter sleep agents. Very importantly, it's not only clinical trials in terms of efficacy, but in terms of safety. There have been serious concerns about some of these products in terms of liver function, such as kava, and I think that this idea that how bad could it be is a real issue. The other thing, it's not only that we don't know whether they work or not, but we don't really know what's in those things. There's very little quality control, and there's recently been reports on what's in them. So while they can't talk about specific disorders, they can talk about certain behaviors. Like this is used to promote regular sleep patterns and to promote normal sleep. People in the sleep and geriatric community have great concerns about that. To sort of say we're not treating, a medical disorder, we're just treating, the fact that you can't sleep at night, it's splitting hairs and probably an injustice. So, but we're going to leave that for now, and let's talk to the main topic at hand, which is the use of over-the-counter sleep agents. So as we turn to sleep, the other thing which is very important about 20% of the population use is to use alcohol as the sleep agent. Now it's very important to understand it's not alcohol per se which disturbs sleep. The problem isn't that people drink alcohol. The problem is they stop drinking when they go to bed. So alcohol actually hastens sleep onset. So if you drink alcohol, it actually makes you fall asleep faster. The problem is you metabolize alcohol, and as you metabolize alcohol, it fragments your sleep tremendously. It fragments your REM sleep. So unless you're going to put in an IV line and infuse alcohol all night, this is a really bad thing to do. So alcohol just fragments sleep. If you're a snorer and you drink alcohol, it'll give you sleep apnea. So alcohol does 2 things to sleep. It makes it bad, and it makes it very bad. So those are the only 2 options. So as I said, let's go to what we're talking about, which is over-the-counter sleep agents. And again, as I said, it's not that complicated because we only have 2 agents out there, doxylamine and Dihenhydramine. Both of those medications are very, very similar, and we'll talk about each of those in turn and some of the brand names they're sold under. It is very important to understand, unlike the herbals, these are approved by the Food and Drug Administration, but unlike the prescription medications, these 2 are specifically approved by monograph. And what that means in plain language is they're grandfathered in. Right about the middle of the 1970s, the Food and Drug Administration, we have all these compounds in there. What are we going to do? We're going to get rid of all of them. We're going to accept some of them. And they reviewed the literature, and they said we're going to take this and this and this. And they accepted doxylamine and Dihenhydramine. But this is without systematic data. They do not treat insomnia. They treat sleep disturbances. And we talked about and Dr. Albert talked about the differences between that. And they're indicated for occasional sleepiness for 2 or 3 nights, unlike the hypnotics, which are indicated for as much as nightly use for long periods of time. So let's talk about these in turn. Doxylamine, there's a bunch of brand names there for you. Unisom sleep tabs, Good Sense sleep aids, and it's mostly all of them. Now it's very important. While they're talked about as antihistamines, I'll show you in a couple of minutes the actual data. They're almost as much anticholinergic, M1 receptor, muscarinic receptors, as they are antihistaminics. So there's a very low H1/M1 potency ratio. The category B for pregnancy, which is not a major topic today since we're doing the elderly. And there's no published placebo-controlled trials supporting the efficacy of this in older adults. In fact, there's no published trials for this medication specifically in anybody. Next slide. The next medication is diphenhydramine, and it's present in a lot more medications. It's present in 90% of the over-the-counter agents, and it's also present in virtually all of the pain sleep combinations, so things like Tylenol PM, Excedrin PM, Advil PM. The PM is almost invariably diphenhydramine. Like the doxylamine, it's an H1 antagonist, but not very specific for the H1. Its H1-M1 potency ratio is low. Again, pregnancy, category B, there's virtually half dozen published studies. Subsequently, there's only one in older individuals, and that we need a lot more data since they use the medications. As you'll hear from Dr. Albert in a few minutes, they use it differentially. So we need more data, not less data in elderly. I think that's just a real challenge for us. Next slide. Now, this is where we keep talking about this M1, H1, relative potency, and you can see that line. The M1, which is the anticholinergic activity, is almost as much as the H1, which is antihistaminic activity. And in fact, if you look it up in pharmacology books, they talk about this as an anticholinergic. And I'll talk about something called the Beers criteria, which sort of classifies this as an anticholinergic. Next slide, please. Now, what else is important? Well, diphenhydramine. There's no data on doxylamine in terms of PK, but diphenhydramine, we have three groups of people here. We have young people, 9 years old, middle-aged people, 31 years old, and this was a study done in 1990. In 1990, 69-year-olds were older people. I would have to argue that they're not older people today. I talk about this out of personal experience. I no longer want to consider 69 years an older person, but at the end of the day, it's not what age you are, but with increasing age, you metabolize these drugs more slowly. We tend to think that children need lower doses. No, they need bigger doses because they metabolize it more quickly. Elderly people metabolize slowly. You can see the blood level is higher and it stays in the system higher, so they have potentially more side effects. Let's talk about some of those side effects. Okay? So here we have an imaging study, and this study looks at two antihistamines. One is diphenhydramine. The other one is ripostazine, which we don't have available in the United States, but it's very similar to the second-generation antihistamines, the non-sedating antihistamines. And then we have placebo. And what you can see is the non-sedating antihistamine, which doesn't penetrate the brain. I can give you the brands of those if you want to know. Everybody knows what the non-sedating antihistamines are. They're advertised all the time on television. They don't hang around the next morning, but 8 hours after they take diphenhydramine, 50 milligrams, the therapeutic dose, you can see that there's a decrease in brain metabolism. That is, the drug continues to suppress central nervous system depression. Now, I personally love imaging studies because you don't have to worry about numbers. You can just simply look at colors. Colors are so much less complicated. Pink is bright, high metabolism, dark, no big deal. I don't have to worry about 7s and 8s and things like that. But let's look at some numbers. Next slide. So this is the Stanford Sleepiness Scale, which measures how sleepy you are the next day in the same study. And you can see that people taking diphenhydramine were significantly more sleepy than people taking placebo with the non-sedating antihistamine somewhere in between there. And finally, let's get very practical, and let's look at actual human performance. And so here we have a series of tasks, things like word lists, which is memory, vocabulary, dexterity, like tapping tasks, cancellation tasks. I'm not going to read all of these for you. And this sort of compares two drugs. One is diphenhydramine, and the other one is temazepam or Restorel, which is a prescription, one of those benzodiazepine receptor agonists I talked about briefly originally. And you can see on those 9 tasks, 1, 2, 3, 4, 5, 6, 7, 8 tasks, diphenhydramine is worse than placebo on 5 of those, and temazepam is worse than 8 of those. So very clearly, this has very little to do with whether you're prescription or non-prescription. It has to do with the fact that both of these drugs have about 12, 13-hour half-lives. So if you take a drug with a 12 to 13-hour half-life and you get out of bed after 8 hours, this is what you're going to look like. You're going to be impaired. So it's very important to understand that you don't get less impairment just because you're over the counter. It has nothing to do with over the counter, under the counter. It has to do with 12-hour half-lives. Next slide. Now, one final consideration in terms of safety, and this comes from the Beers criteria, which is widely distributed, and that is the big concern in the elderly with anticholinergic drugs. Dr. Alves will talk to you about how frequently elderly people take a variety of anticholinergic drugs. Well, adding a sleeping agent, diphenhydramine, which we think of an antihistamine, makes that much more complicated. And So very clearly, the use of things like diphenhydramine and oxylamine on his list of anticholinergic examples is a real problem, and the highly anticholinergic clearance is reduced with advanced sedation. We show that the clearance of these drugs are decreased with elderly because they have slower metabolisms. And that gives us tolerance to the anticholinergic activity, and that also increases the dose when it's used as a hypnotic. It has an increased risk of confusion, dry mouth, all of the things we know, in terms of urinary activity. So all of these things we know in terms of anticholinergic activity become side effects of these drugs, which we think of as antihistamines, but are really anticholinergics. And I think the Beers criteria sort of highlights that for us. Next slide, please. So in conclusion, I want to leave you with a couple of real important thoughts. The efficacy of over-the-counter sleep aids in general is not very available. We're really flying blind. We're using this medication with blindness. In the elderly, we're fine with almost total blindness. So I think to use these, I know you don't have to use them, but to sort of use these without talking to your physician a little bit is probably not a wise idea at the present time. The duration of action of diphenhydramine increases with age. So we're talking about the elderly today. If it's a problem for you, so if you talk to somebody who's 30 and said they had a great experience with the drug, it may not generalize to you. So your daughter says, I used it, it worked for me, it may not work for you, and I think that's an important thing to realize. The safety concerns were the results of two things, the residual effects I talked to you about, and the anticholinergic effects, which the BS criteria highlights. So many adults increase the misuse of over-the-counter sleep agents, taking them for long periods of time, which is not recommended. And Dr. Abbott will give you specific data, which we now have available to us about the nature of the use of these medications in the elderly.
Thank you, Dr. Roth, and thank you, Dr. Vitiello. I think we've set the scene very well for the prevalence of sleep disturbance in old age and some of the limitations of our current therapies. Let's turn now to what we know about how older people actually use these medications, which will, I think, alert us to some of the gaps and where we need to concentrate our efforts. So we're very fortunate to have access to the National Health and Wellness Survey conducted by Kantar International. It's one of the few surveys we've been able to identify that asks a large nationally representative sample about sleeplessness symptoms, but also elicits in great detail prescription and OTC medication use to treat those symptoms. This is a sample of people aged 18 plus, and as I said, nationally representative of the U.S. population. And one of the first things, maybe not so much a surprise, but given what we've heard already, Americans have a little trouble with sleep. Nearly half of the adults in this sample report at least some sleeplessness symptoms in the past year. And even about a third of these folks report daytime sleepiness symptoms, which is a concern for reasons we've heard already. Let's continue. And you can see that people do make use of these medications, but this is an important slide, so I think we should linger on it a little bit. So of those older people, that half the population who reports a sleep problem, and now drilling down to people age 65 plus, about a quarter are taking a prescription medication. And that's an important finding. It means that 3/4 are not, first of all. But the quarter that do, you can see that the most commonly used drugs are these listed. Ambien, one of the Z drugs, is the most common, and you can get a look there. It's interesting from our perspective is that not all of these older adults actually say they've been diagnosed with insomnia, but they are taking some of these prescription drugs to address sleeplessness issues or sleep disturbance. You can look at the next slide. Here, on the other hand, is the recourse to the OTC herbal products. Again, we're drilling down to older people who report sleep problems. Here, about a third, or a little more than a third, report that they've made use of an OTC sleep aid in the past year. And the most common drug here is actually a supplement, melatonin. But after that, you can see the drugs with diphenhydramine or doxylamine that we've already mentioned. The Tylenol products, the PM products are very common, the Benadryl products, and on and on. And you can see that people are making extensive use of sleep aids. the question for us is, does it differ by age or by comorbidity or perhaps by other drugs that people might be taking? So we can begin to take a look at this. First, one thing of interest is that you don't see big differences over the life course in recourse to these therapies among those people reporting a sleep difficulty who are using these drugs. So across the three bands of age, 18 to 64, 65 to 74, and 75 plus, about half are not doing anything with respect to OTC, herbal, or prescription medications. And then if you look more particularly at the complete set of options people take advantage of, there aren't strong differences by age. Maybe 15 to 20% are only using a prescription, 12% only an OTC, 10% or so only an herbal, and every combination of those products. So our first interesting finding is that at least recourse to the drugs does not seem to be so different across the lifespan among those people who report sleep disturbance. However, if you look at the way people actually take the drugs, here we have an important finding which we think merits a lot more discussion and is potentially a little concerning. So take a look. One rough way to think about inappropriate use or unintentional misuse is to be taking these drugs longer than you should every month. Now, a very conservative estimate of overuse is people who report to us that they're taking the drug for 14 or more than 14 days each month. Remember that the OTCs are designed for short-term use of about three days in a week. But here we have people who tell us that they routinely take the medicine for more than 14 days each month. And it's not specific to old age. You can see that about 21% of people 18 to 64 report such use. But by the time you're getting to the 75 pluses, it's double that, 47%. And why that should be is a little mysterious. And this is a great topic of interest, I think. What are we doing wrong about communicating information about this drug use? What proportion of these people are actually using the OTC medications to treat insomnia? Why people get into the habit of adding OTC medications to their daily set of meds? All, I think, are great questions, and they become a little more concerning when we look at some of the other drugs people are taking. So here, for example, are in this subset of people who report sleeplessness and who are also taking diphenhydramine or doxylamine, you can get a sense of the proportion who are also taking anticholinergic drug. And here, too, you see great increases over the lifespan, a doubling between ages 18 to 64 and 75 plus, so that fully 44% of people taking diphenhydramine among this older subset of people are also taking anticholinergic drugs. And as you heard from Dr. Roth, diphenhydramine is anticholinergic and antihistaminic, and probably it represents an overuse of anticholinergic medicines with all the consequences that we've heard already. So again, a concern. So just looking again now to summarize from what we've learned from our look at the survey data nationally, the National Health and Wellness Survey data confirm observations from other studies we've heard, but now on a population basis. Sleeplessness symptoms are very common in the U.S. adult population. Individuals self-report sleep difficulties in different ways. It's important for healthcare professionals to discuss these with patients. Certainly the length of time that people have had these sleep difficulties and the need to check sources for sleep disturbance is paramount. We see among older adults much higher off-label use of OTC sleep aids, that is, taking the drug longer than they should. I think it's sorts of people are taking, and clearly there's an opportunity to educate healthcare professionals on the treatment and safety concerns that we see with these drugs. So I just want to draw your attention now to some of the resources available at the GSA website. We've had a number of reports and white papers available, handouts that you can use that summarize results from our research and summaries. I encourage you to go to these websites. On deck are video and webinars that healthcare professionals can use to update their knowledge about OTC sleep aids. And we're going to turn the floor over to you in a second. If you have questions, please let us know. We think we've set the scene for a rich discussion and hope we've answered some of your questions or maybe provoked some. So let me, before I switch over to you, just thank my colleagues, Dr. Vitiello and Dr. Roth, for their participation today, and thank you also to Pfizer for providing support for this program. Before we move to the question and answer portion of the program, I'd like also to remind you that we are recording this session. We can send you an access link by email once the recording is available. You'll also be able to download a copy of the slides which we've shown and recommendations that we have in our reports from the website listed at the end of this presentation. So you'll also have a chance to complete a short survey after the webinar, and we need this for our efforts to continually improve the quality of the webinars we present. So please provide feedback by clicking on the survey link at the end of the webinar. Now we're going to move to questions and answers. Let me just remind you again that you can type and send questions using the questionnaires feature in the dashboard. That's accessible on the right-hand side of your screen. We won't be using the raised hand feature today, so if you have a question, just use the questions panel. Dr. Vitiello, Dr. Roth, and I will do our best to answer as many questions as possible, time permitting. We have about 15 minutes, so feel free to send along any questions. And just to get the ball rolling, let me throw out one or two that we've heard at this end. And there is a question really about how much sleep should older people get? This is a question I think we often hear. I would love my panelists, Dr. Roth and Dr. Vitiello, to talk a little bit about this issue.
You know, again, I'm not going to give a direct answer. I highly recommend you go to the National Sleep Foundation website where they have, in collaboration with the GSA, did a program looking at sleep need as a function of age, and they have recommendations for the elderly. But I think as we age, the issue isn't how many hours of sleep we get, but it's really the quality of sleep. If you're sleeping 10 hours a night and you're waking up feeling worse than when you went to bed, that's not getting adequate sleep. So it's not simply how many hours of sleep you get, but what is the quality of your sleep? How refreshing is it? If you feel that you haven't slept enough, you haven't slept enough. If the book says you need 7 to 8, you slept 7, and you feel tired when you wake up in the morning, go talk to your doctor.
Great, thank you. We have a question that's just come in. The question is, could you relate the efficacy of behavioral therapy versus pharmaceuticals?
I'd be happy to answer that. There's been quite a bit of research in the area of cognitive behavioral therapy for insomnia, which has demonstrated a number of important things. First, cognitive behavioral therapy for insomnia is as efficacious in young adults in older adults as it is in young adults. That's been shown in a number of studies. Secondly, there have been meta-analyses that have looked at the effect sizes of cognitive behavioral therapy for insomnia versus pharmacotherapy, and have shown at the very least that they are comparable in their ability to improve sleep. Third, there's also been a recent literature that has shown that CBTI works not just in unconscious in older adults, but in insomnia in the presence of a variety of morbid illnesses. That includes depression, pain syndromes, recovery from alcohol, and a number of other disorders. there are some other studies that have looked at not just specialized populations, but also primary care populations, and shown that CBTI, again, is efficacious. So it's a major tool in improving sleep in not just the general population, but in older adults. The important thing to recognize is that it is a procedure which takes time, energy, and a professional, but there's a lot that older adults can do to improve their sleep just by reviewing the things that they can do behaviorally to maximize their sleep environments, to maximize their sleep habits and behaviors. And that would be the first step towards improving sleep at the behavioral level. And if those steps fail or are not sufficient for the individual, then they might want to seek out more professional things that CBTI would entail, which would typically mean either going to a sleep center or locating a clinical psychologist or nurse practitioner that could provide these services.
Good. A question that often comes up is, what can pharmacists do, given that we're talking about OTCs, to help older adults navigate use of these medications? Dr. Roth or Dr. Vitiello?
I'm not a pharmacist, so it's very hard for me to answer that. But I mean, you know, one of the things that you pointed out, which I think is incredibly important, which is very unique to the elderly. You know, one of the big advices to the elderly, you know, many geriatricians say, stop all the medications and start over. So one of the things a pharmacist can do is he has access to all the medications that that patient has very often, probably better than the patient themselves. And he can look at how many anticholinergics he has. What is the total anticholinergic load? So, for example, if you look at risk of falls in the elderly, it's not because of this drug or that drug or that drug. It's due to the total sedative/anticholinergic load. And he is in a unique position to do that. So I think they can be tremendously valuable. I think, again, like in the case of physicians, they're not going to jump from behind the counter. The doctor's not going to jump from behind the office and raise these questions with you. It's up to each of us as individuals to ask the pharmacist to help us with this, and I think they'd be happy to do that.
Very good. Okay. Another question we often get is, do women in old age have more sleep problems than men? Is it a women's health issue?
Well, that's, again, another complex question that's not easy to ask. We do know that women complain more of sleep problems. That's demonstrated in, I think, every study that's ever looked at epidemiological sleep complaints. As to exactly why, we don't know, because objectively, women's sleep is often less compromised in studies that compare the two. So we're either not measuring the right things in those studies, or we're not sensitive to some of the reasons that women experience and complain about sleep problems. It may be that certainly at earlier ages in older adults, in the perimenopausal years, that's going to have a significant impact on sleep. And to assume that those changes go away quickly actually shouldn't be done automatically. There's a lot of data that's emerging that suggests that hot flashes, for example, which have significant impact on sleep problems, persist very often years after the perimenopausal years. So you could be a woman out in your 60s and 70s and still be experiencing significant hot flashes. There may be other reasons to account for that, but again, while there are gender differences, we don't have the best handle on why they exist.
You know, one of the things that's important is, you know, when people sort of talk about menopause, people try to come up with endocrinological answers to that. And then I just want to point out, the prevalence of insomnia in men and women is exactly the same until women start menstruating. That is the first big bump, where women have much more insomnia than men. They also have much more depression at that point in their lives than men. The second big bump comes when they stop menstruating. So I think what's very important is we not only have to think about these endocrinologically, we have to think about these in terms of the stress or the social impact of starting to menstruate, or stopping to menstruate. These are not trivial social, psychological events. And for the record, I think it's important to point out that my wife really believes that the reason women have more insomnia than men is most of them are married to men.
Okay.
I think that very personally.
We've had a few questions come in. Let me turn these. I'll just summarize the question. One asks, what is the right cut point for defining short sleep? Some studies use less than 5 hours. Some use less than 6 hours. Is there any support or justification for these numbers? What is the good definition of inadequate sleep?
Well, let me first respond to that by saying that the question has somewhat turned the data on its head. The data that we reported showing risk factors for falls and morbidity in certain populations really used a series of cut points and then found the cut points which provided the risk factors. So it's not that they defined short sleep as X or Y. They would have explored 5 hours and 6 hours in both samples, but the risk factors emerged at a certain level of sleep shortage there. That being said, it's very difficult to provide an exact cut factor. And indeed, typically there's a range of variation and there are individual differences. Some people are just short sleepers, always have been, always will be. The fact that their sleep may truncate an hour as they age is very different from somebody else who starts out as a longer sleeper who may be more greatly truncated. So it's really an individual difference. And a lot of these studies use population averages, and you can't necessarily assume you can go from the population to the individual.
Good.
I think as an individual, you ought to, if you want to know if you're getting enough sleep or not, the two things I would ask myself is, one, on days when I'm off, do I sleep more than days when I'm working? B, do I find myself dozing off at meetings and I don't want to doze off? Am I taking what we call involuntary naps and non-planned naps? So if you're sleeping more on weekends, if you're taking on-scheduled naps, okay, you're not sleeping enough. I don't care if it's 5, 6, or 7, it is not enough. And the second thing is, how much coffee do you drink? The American society drinks more coffee than any other country in the universe. And the most popular selling branded coffees are those with the highest caffeine content. So if you drink a lot of coffee, if you sleep more on days off, the answer is, I don't care about the number, you've got to raise that number.
Good. Yes, there's a difference also between the quality of the sleep and
Absolutely.
the length of sleep time. We have another question that's just come in, but let me add a little caveat. We can't provide medical advice here per se. This is a clinical question, but I will throw it out to our panelists. We have a question about an 82-year-old female, their weight of 80 pounds, who's taking Zolpidem and seems to be taking an additional dose at 5 a.m. when she wakes. And according to a family member, she's also using Diphenhydramine, but does not seem to have she has a picture of clinical history of cancer, but no cardiovascular disease or diabetes. And the question is, do we have any management suggestions?
I would suggest she doesn't drive.
Okay.
Honestly, I mean, taking a sedative hypnotic drug at 5 in the morning puts you at risk for all kinds of potential psychomotor problems during the day, assuming she gets up any time. And just, I'm not a physician, so I can't speak to how one might treat her long term. But she should certainly be cautioned against doing anything in the daytime that would put her at risk in the context of that drug load.
I mean, clearly, this is a person who either herself, by her initiative, or by her family's initiative, should be seeking a physician's advice on what to do with this. Taking sedative hypnotics at that dose, at that age, at that body weight, at those times, is singularly inappropriate. It's possible it's okay, but she's not metabolizing them. I don't know the answer to that. Nobody knows the answer to that. But she should find out the answer to that by going to a physician. And if it's your relative, we would encourage you to do that.
So the recommendation is a physician consult is
Absolutely.
probably the appropriate.
Absolutely.
Okay, well, our time is almost up. If you have any other questions out there, please send them in. If not, I will just at this point transition to the end of our session and thank everyone again for joining us remotely or in the room here in Washington, D.C. I want to remind you again to please visit our website, and you will, at the GSA, the Gerontological Society of America, many resources available to amplify this discussion. You'll be getting a link to the copy of the slides and audio. If that's of interest, feel free to take advantage of it. Please, if you can, complete the survey that will pop up, I think, at the end of this webinar. And thank you again feedback, and I think you will hear in the next year further research in this area as we try to address this very important public health issue and in older adults. And I thank you again. Goodbye now.